Good afternoon, everyone. First of all, I thank organizing committee to give me opportunity to chair the session. Dr. Kiran Patel, he is BDS from 𝑘𝒄𝒕𝒊𝒄𝒂𝒍 Dental College, Vadodara, MDS from 𝑪𝒐𝒓𝒕𝒊𝒄𝒂𝒍 Dental College, Meerut, Masters in Immediate Loaded Implantology from International Implant Foundation, Munich, Germany. He is pioneer of 𝑠hreyas Multi-Specialty Dental Hospital, achieved expertise in permanent dental implantation within 72 hours, accomplished more than 5,000 successful implant placements with expert strategic implantologists. I welcome you, sir.
Thank you. Good afternoon, everyone. My topic is mostly dedicated to those doctors who want to start basal implantology in their practice. And my presentation is about to highlight how to insert bicortical screw. Basal implant it is the true basal implant, which is the bicortical screw, or we have the lateral basal implant. I am not going to discuss about the KOS and various other designs because there are other dedicated lectures are there for that. I am going to concentrate and focus on the bicortical screw. Now, for the beginners, there are many doubts and questions have to start with this science because it is requiring little technical skills, we can say, but that is required for the controlled insertion of bicortical screw and the true bicortical anchorage we should get. How to start the strategic implantology? Start from the very basic, that is the patient selection, then the clinical scenario, and then the technical issues are there. I am going to describe each one in detail. The patient selection, first of all, when you are starting, please say no to high expectation patients because it's obvious there are mistakes are bound to happen and that can give you sleepless nights. So say no to high expectation patients. Restricted mouth opening, avoid when you want to start the basal implantology, then avoid the cases which have a restricted mouth opening. Onco patient resection cases, that can be done after you achieve some mastery in the bicortical screw. When patient is not ready to do something in the opposing arch, when you are treating one arch and an opposing arch and natural dentition or some missing, some broken, some hook cooked, and patient is not willing to do treatment in the opposing arch, in those cases you should tell them no because we have a prescribed prosthetic protocol. Placement is not the only success. The success is the occlusion. If you do not have the proper occlusion as prescribed by the IF standard, then it is going to fail, and that can give you trouble. Parafunctional habit, you can treat the parafunctional habit beforehand, then starting the implant treatment. Yes, radiological CBCT is most important to identify the vital structure, but OPG is good for us. What we should look in the OPG, we should look all the white lines. These are the strategic position, or what we call the second and bicortical or the third cortical bone, where it is the target area where we have to insert our bicortical screw. So we should look for this nasal floor, sinus floor, then the pterygoid bone, external oblique ridge in the mandible, internal oblique ridge in the mandible. These are highly corticalized bone and which can give you a white line in the OPG. We should look for that we are going to treat this patient and we can easily able to insert bicortical screw. Look for the condylar head in the OPG because most of the patients are unilateral chewer or patient having any parafunctional habit. There will be a change in the dimension and size of the head of condyle. We should look for that before treatment planning, and then accordingly we have to give the prosthesis because we need to give a balanced occlusion. Patient should not continue unilateral pattern of chewing post-operative also because that can lead to failure.